office, whether we work in the Ministry of Health, sit on a hospital board, or any or whoever we are, all right, we raise the picture. We will raise, all right, on the picture on the left. That is the healthcare as a cost center, all right, whether we realize it or not. So the old model, healthcare as a cost center, meaning to say that we are being pictured as inflationary burden, where health spending treated as a line item that only ever climbs, competing ever budget cycle with education, defense, infrastructure for the same limited pool of money. And under this traditional cost center, we are talking about where we see it is a reactive treatment. The system waits for people to get sick, and then we spend heavily to fix them rather than spending a little earlier to stop the problem developing in the first place. But if you look on the right hand side, we can see that it is healthcare. The new model is a healthcare as economic engine. Mean to say that we have to be proactive prevention using continuous data from a wearable apps, even a simple SMS check-in to catch a problem. For example, like rising of blood pressure, right? Month before it turns into hospital admission. So it's like we can predict earlier. And under this new model, we talk about scalable value creation. Once a good digital screening tool exists, serving the 1 million patient costs only a little more than serving the first. Compare that to a hospital bed, which has to be built brick by brick and then nurse by nurse to ensure no shots available. So let me bring this home with figures you recognize. For example, in Malaysia, we have a health white paper plainly in writing that the current model isn't fiscal sustainable given aging population at one of the highest diabetes rates in the Asia Pacific region. And if you know that Malaysia is number one, right, for obesity, all right, which is we are not so proud of it, right? But we have to be really concerned about it. Indonesia version of the same story, if anything, sharper, the national insurance scheme. You have, if not mistaken, Indonesia, you have Badan Penyelenggaraan Jaminan Sosial, JBPS, if I'm not mistaken, right? Where has wrestled for years with funding shortfalls, largely because it inherited almost the entire architecture of the model of the on the left, focusing so much on the left, the old model, instead of looking into the right one, that is to make healthcare as economic engine. So bring back, let's talk number for a moment because I'm from business school, business economic school. So because talk about business models really ought to earn its keep with some figures, not just philosophy. So we are talking about facts. So the global digital health market is expected to reach somewhere around 934.8 US dollar by 2030, up roughly from 348 US dollar in 2024. So we can see that works out to a compound annual growth rate, meaning that the average yearly growth once you compound it over several years of about 17.9%. Almost no piece of traditional healthcare infrastructure goes everywhere close to that pace. But honestly, the sentence that matters most on this slide is on the printed quietly at the bottom. If you see the orange color, all right. What I want to bring here is that despite the record funding, demographic pressures and chronic disease burdens means we cannot build physical hospitals fast enough because of the demographic and also because of the locations that we have, especially Indonesia. You have so many islands, right? So so digital scale is the only mathematical solution. So that's why we need to look into this in deeply. So like I said just now, if I'm not mistaken, correct me if I'm wrong, Indonesia, you have around 280 million people, around 17,000 islands, right? So actually there's no construction budget and number of years in which Indonesia could physically build enough hospital beds and train enough specialists to cater all these islands to reach every citizen through bricks and mortar alone. Same goes to Malaysia. We have specialists, but it's quite difficult for us to cater people in rural area, in Kelantan, in Sarawak, in Sabah, and so on. So when I say digital tools aren't luxury add-on to the health system, I mean it quite literally. So that's what we need to think about. So I want to give you a phrase now that I hope you still remember a year from now, that is called pilot graveyard. All right. If you can see here, what is I'm going to share with you and explain you about the pilot graveyard. All right. Here's the pattern, and I think you academicians and also researchers, we have come across this. Um, for example, we have a talented team, often backed by university, development agency, or well-meaning NGOs, and then we build something genuinely very good, apps, AI, and so on. It gets piloted in one district, one hospital, with a number of people, population. The results look wonderful based on the pilot. Then we have a ribbon cutting for us to officiate it and so on, and then we have a conference paper published and it goes on, and then suddenly it stopped quietly, nothing. The grant that is given runs out after 18 months or 2 years. Then the person who championed the whole thing moves to a new job, and then the tool just fade away. All right, nothing happened. What happened to the apps? It's not being used. It's only just a pilot at that moment. So then right there is what we call the pilot graveyard, a vast, most invisible cemetery of promising pilots that never crossed the bridge to what this site calls system-wide impact. So this has been repeatedly across our region. A number of donor-funded maternal health, SMS programs, telemedicine trials everywhere, to remote provinces to produce excellent clinical results during the pilot phase. Yes, it is excellent, only to be quietly discontinued the moment the initial grant expired, simply because nobody had built a way of paying for the servers, paying for the staff, for the connectivity that could survive without it. So like for example, in Malaysia, we have MySejahtera that was introduced when we had the COVID-19 pandemic in 2020, but now it is like in the graveyard. We didn't use it anymore. All right. So that is a simple example that we can look into. So we can see that from this slide, the previous one, we look at the disease or we look at the problems. So this one starts on the cure, and the operative word here is iterative. A digital health business model simply cannot be designed once on the paper, on a whiteboard, or wherever it is, that run unchanged for the next 10 years. It has to be built, it has to bend, and it has to be adapt, because the ground underneath the digital system is regulations, the reimbursement rules, and the technology itself. And we talk about technology, it keeps on changing from time to time, from month to month, from weeks to weeks. So if you look here, I use the term regulatory ambiguity sitting right there on the slide. In my view, this is one of the single biggest reasons digital health venture is part of the world's struggle to scale. For example, we take an AI based diagnostic tools, right? It is a medical device requiring formal approval, for example, in Malaysia. So we have all these devices. So is it a medical device requiring formal approval from Malaysia's Medical Device Authority, or is it just software escaping the scrutiny entirely? So honestly, the rules are still rewritten even as companies try to launch it, right? So it is a big obstacle there. So here's the practical lesson for anybody who wants to come up with your own apps or any AI digital healthcare system, because the regulatory environment is generally ambiguous and generally still evolving. Your strategy cannot be rigid 5-year carved in the stoneware everywhere. It has to be itinerary loop, launching something that fits to these rules, and then gather real evidence, and then you treat regulators as partners in the conversation rather than obstacles to work around. All right. So So this for me is one of the most useful framework for my talk. So bear with me while I go through this pillar. So when we talk pillar is very crucial and is very important. Who tends to go wrong when a venture neglects one of them? So in order for us to overcome all the problems that I mentioned earlier, right, we need to have a viable, diversified, proven reimbursement. Meaning to say that a venture needs more than a single paying customer segment, perhaps a blend of direct patient payments, insurance reimbursement, employer contract. If you skip this, then you get what the slide calls financially fragility. One funding tag gets turned off and the whole things collapse. Exactly the way what we see in the pilot graveyard previously. And second one is we talk about measurable. You have to be able to show with real clinical evidence that the thing actually improves health. Sorry. If you skip this, then doctors won't recommend a tool with no proven benefits, definitely, right? Because we talk about facts, science, and staff who are forced to use it anyway, then they will start to have a burnout. And next one is about efficient. The tool has to be the tool has to make an existing clinical workflow smoother. If you skip this, you get gridlock, meaning to say that nurses entering the same data twice. You key in the system, you key in using the apps, but at the same time, you have to do it manually until eventually they just stop bothering about key in the data. So it is happening now, right? Because I have my nieces who are working as a nurse. She's having the same problem in regards to efficiency. And we talk about universal. The solution has to be designed to reach the poorest, most remote citizens, not just affluent or those who have smartphone, right? If you end up with this, then what will happen is that we will have a digital divide, a tutor system where the wealthy get proactive, the wealthy will get the AI assisted care, while the poor are left behind with an even more stretched physical system because of the resources that is quietly drifted toward building the shiny digital layer instead. For example, like in Indonesia, you have Hello Doc, right? Hello Doc. So the underlying platform, the app, the logistic engine, the algorithm matching you to a doctor is the same nationwide, right? But in central Jakarta, the service will come very fast, right? Maybe within the hour. But what about those who are living in the remote area? In Nusa Tenggara and other rural places, right? So the same platform they use, but they will get the teleconsultations and so on. They will get the help maybe several days because of the logistic issues and so on. Now we understand why sustainability matters. Let's get practical about how we actually design a business model in the first place. What you see here is simplified version of, in business, we call it as business model Canva to boil down the 4 questions. So we need to give a value, right? What unique benefits are we offering and to whom specifically? For consultation, teleconsultation platform, for example, the value proposition to a busy professional, for example, in Malaysia, Kuala Lumpur, might be see a doctor in 15 minutes without leaving your desk, while a rural patient in Sabah, for example, might simply see a doctor at all without losing a whole day traveling. Then we need to give value creation. Value creation meaning that what activities, resources, and partners does it actually take to deliver on that promise? The technology itself, of course, but also the funding behind it, critically outside partners, whether that's courier network for medicine delivery or a telco's company for connectivity. Then we have to look into the value capture. How does the venture actually make money? What are the revenue streams and what does it cost to run in fixed versus variable terms? This honestly is where so many pilots quietly fall apart. No, and until now, it's quite difficult for us to get the answer towards the pilot graveyard, as what I mentioned earlier. And lastly, it's about value communication and delivery. Through which channels, physical or digital, do you actually reach the people? And how do you build enough of relationship that they come back rather than trying you once of curiosity and never returning, meaning to say that they just use it once and then they are not going to use it anymore. So if they are not using anymore the digital apps and so on, then it's just a waste of time, waste of money and so on. Yeah. So these slides want to bring you to a short history lesson in how digital health has learned sometimes the hard way to make money, organized into three phases. So we can see the phase one is the where we have one offshore licensing, single isolated consultation, fee paid once, and then we don't know what happened after that. Think of like buying a cinema single ticket, you watch movie, you pay, you watch, you leave, and there's no ongoing relationship, no recurring revenue, frankly, no incentive at all for the platform to keep you healthy over time. And then we go to the second phase, that is transition models, patient subscriptions and sales of what we call digital therapeutic, software-based interventions. Sometimes we have physician prescribe that treat a condition directly, say an app-guided program for managing diabetes and so on. Alongside those, business-to-business employer wellness programs started appearing where a company pays for its whole workforce to access telemedicine or wellness platform. And then we go to the last phase, that is the sustainable ecosystem. That is the current one that we have, where a deliberate blend of physical and digital touch points. So you might message a nurse through an app, but still visit a clinical physical clinic for a blood draw. So we can see that we still have to have a human touch, value-based, customer-driven contracts that the provider gets paid for the health outcome actually achieved, not simply for the service rendered. So this is where we have to understand that the revenue comes from the whole connected ecosystem of a care, not only one isolated transaction. From any of these convenes, we need to be able to measure the return, and this slide reminds us that ROI isn't one number, it's a three running in parallel. So I put here, we have clinical ROI, we have financial ROI, and also social ROI. So clinical ROI, meaning that we, of course, we need to look for better health behavior, improve medication adherence, meaning patients actually that what's been prescribed on schedule, earlier detection of risk before it becomes a crisis. At the same time, we look into the financial ROI, less reliance on expensive emergency care, fewer hospitals admissions, lower workplace absenteeism, and of course, all of it is about real money saved for health system insurers and employers alike. And social ROI, where we want to narrow health gaps between the rich and the poor, urban and rural, better equity of access, and public health system that's simply more capable of responding when the next crisis hits. Right, so we learned from what happened during the pandemic. So we need to do something about it. So this slide notes that national public health initiatives backed by digital tools can return several times that was invested, with a genuinely health median ROI, which is precisely the kind of multi-year, multi-dimensional evidence of finance ministry in any countries needs to see before committing public money at national scale. For example, like what I said just now, we have MySejahtera in Malaysia, right? That was originally built for COVID-19, right? To track contact tracing and vaccination records. But then after that, it's like nothing happened, right? It's just that it's in the phone, but it's not used anymore. Okay, I'm not going to brush into in detail, but here is what I want to share with you. This is about daily disability adjusted life year that measures one lost year of healthy life, whether lost to early death or to year live with illness or disability. Kaylee is a quality adjusted life year, measures a year of life adjusted of how healthy that year actually was. A year in a perfect health counts as one fully Kaylee. A year with serious illness counts as less, right? So this is health economists everywhere use cost per daily averted as cost per Kaylee gained, right? So this is very interesting if we really dig into it. So we can see here where workplace digital wellness program costs roughly 10 US dollar to 300 per employee with a modest return, around 1.5 year to 2 times invested over 3 years. But the scale very easily because employees love anything that is visibly boost their productivity. So for example, in Malaysia, all right, Malaysia's tobacco control and vaping cessation efforts run through the Ministry of Health, increasingly lean on SMS, apps based nudges precisely because of the cost profile, right? Is extraordinarily cheap per life, safe compared with treating advanced lung disease over the line. In Indonesia, I believe, given its geographic sprawl, it's almost tailor-made for digital hypertension and diabetes monitoring through community health posts. One of it, if I'm not mistaken, is Puskesmas, right, where you extend something to close to specialist level oversight into villages a doctor might otherwise visit once a month, only once a month, right?
Well done, Prof. We have about 5 minutes remaining for this presentation.
How many minutes?
5 minutes.
5 minutes.
Yeah.
Okay, all right. Okay, I try be fast as I can. Okay, so we can see from these slides, this is where we can see is a plot of cost and technology complexity, low to high, a return on investment, impact and scalability as low to high. So you can see from these slides, this is a pattern where simply SMS-based adherence reminders is being used, all right, but we have to make sure that the cost and technology is giving a high impact on the ROI as well. And this is the steps, having talked about the sustainable model, right, which kinds of interventions of the best value for money. So these are the steps that is recommended from choosing prioritize high impact technology up to the initiative sustain long-term market competition until to the launch stage. So this is like a healthcare ecosystem that is quietly encouraging to look up to follow, supported by agencies, government agencies, local agencies, all right, to make sure that we choose the best one until the initiative stage itself. And we can see that this is the scaling digital health is not only for individual companies alone, but of course it involves a number of stakeholders from the regulatory up to the strategy partnerships, where we need to, all these players play a crucial role, right, in making sure that we solve the connectivity problem, we can enhance the public procurement, we can make sure that we have a regulatory sandbox to control the environment where the policymakers and private companies can develop fit for the purpose itself. So this, before I close, pulling the financial and technology threads together in one triangle. So what I want to share here is that underneath the diagram is really carrying the whole weight of this keynote. A sustainable digital healthcare aligns private sector innovation with tangible public health outcomes through deliberate market design. So the word deliberate is doing a lot of work here. We need to have a good outcomes, as skills simply do not happen by accident, but they simply don't happen through clever technology alone. So we need to work together in making sure that the funder, the regulator, the investor, the hospital administrator design the price, the reimbursement pathway, so that the company profit can motivate a nation's public health goals at the same direction, same strategy. So we reached to the slide at the end of the slide. All right, so here's the message. I hope that every one of you carries out this hall today. We see that the future of healthcare is not a choice between digital service and human care. The most successful models will combine digital intelligence with human compassion and business innovation with social responsibility. With that, thank you so much. Jazakallah. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Aliza, for your presentation session. It's wonderful. Topics include about healthcare issues, business issues, and the others. For next session, I think we can move on to the second presenter. Is it okay, Prof. Aliza, or you want to
Yeah, can proceed, no
continue?
problem.
Okay. Thank you, Prof. Aliza, for your confirmation. Next session, we have second speaker as Dr. Awanis Romi. She's an associate professor at the Faculty of Computing, University Malaya Pahang Al Sultan Abdullah UMSA, where she also serves as director of Flexible Learning and Micro-Credential Center. She holds a PhD engineer from Cardiff University, United Kingdom, with a research focus on decision-making system, knowledge management, and sustainable design and green IT. Her presentation today is entitled From Data to Value, Leveraging Big Data, AI, and Digital Platform from Smarter Healthcare Solution. Please welcome Dr. Awanis Romi. Assalamualaikum, Dr. Awanis.
Waalaikumsalam. Can you hear my voice?
It's loud and clear. Thank you for joining with us for the second time, Dr. Awanis.
Yes.
So whenever you're ready, please go ahead 30 minutes from now.
Thank you so much. I would like to share my screen.
It's open, ready.
You see? Okay, but let me check first. Wait a minute. I would like to check the presenter view.
Pardon, Dr. Awanis, do you have some problem issues or?
Yes. Wait a minute.
Okay, okay.
I don't know what happened. Right.
If it's possible, we can presenting from here if you don't mind.
Yeah, I would like
Oh,
to
okay.
control. Okay. You see the slide?
Uh, you can, yeah, we can see your presentations, but also the
Sorry, Mr. Farid.
yeah,
Can you see the slide?
yeah, we can see your slide, but in the point of view of your presenter, not us audience. So we can see your notes beside the
So
slide.
you can see the presenter view also here.
Yeah.
Oh, okay.
Uh,
Presenter. Presenter.
yeah, cool. It's good.
Okay. Now
Yeah,
I
good.
like to have the site presenter actually. the, oh, I need to have this presented, the presenter view here
Yeah.
to guide me.
Mm. What if I'm
But
representing your presentation from here, then you can just
okay, can
wait for a
I
while.
need to stop sharing?
Yeah, it's okay.
Okay, good. You share it from your side, right? Sorry, everyone.
Yeah, wait for a while, Dr. Awanis. You're giving us a PDF file, right, Dr. Awanis?
Yes, yes, I give the PDF.
Okay.
And you can do the slideshow, right, for the
Yeah,
PDF? All right,
come on.
perfect. Okay, thank you. May I start? Okay, Assalamualaikum and good morning, everyone. Okay, it is truly a pleasure to be here with all of you. Thank you to Universitas Aisyah Surakarta for inviting me to share this session. Before we begin, I would like to ask you one simple question. How many of you have visited a hospital or clinic within the past year? Okay, please have the interaction here. You may type 1 for yes in the chat, or you can use the emoji thumb up. Okay, I would like to see we have the engagement, the interaction here. Okay, good. So we can see that almost every one of us have go or visited a hospital or clinic. Now, another question. Have you ever been asked to repeat the same medical information more than once? Your name, your medications, your allergies, your medical history, and if your answer is yes, so this brings us to today's topic. The problem is rarely our doctors. The problem is that healthcare information is often stored in different places. Yes, I can see. Yes, I'm tired of it. Prof. Aliza said it. That when the data or the information is stored in different places, they cannot communicate with one another. So today, I'm technologist Dr. Awanis Romli from University Malaysia Pahang of Sultan Abdullah. I would like to share why big data, digital platforms, and artificial intelligence must work together to create smarter healthcare. Because AI alone is not enough. AI needs data, but data only becomes valuable when it is connected. So let's begin our journey. Next slide. I want you to imagine it is 2 o'clock in the morning. Your father suddenly experienced severe chest pain. Your family rushed him to the nearest emergency department. The medical team is ready, but before treatment begins, they ask some important questions. Does your father has any allergies? Is he taking blood thinners? Does he have a history of heart disease? You know this information exists, but it is stored in different places. Okay. So when we look at the left side of the slide, one hospital has his laboratory results. Another clinic has his medical history. So every organization, we know that it owns a piece of the puzzle, but nobody sees the complete picture. Now look at the right side. Imagine the doctor can access one connected health record. Within seconds, his medications appear, his allergies appear, his previous ECG appears. Even his wearable device shows actually the abnormal heart activity before he arrived at the hospital. So the treatment can begin immediately. Same patient, same doctor, same hospital, but a completely different outcome. This is the power of connected healthcare. Next slide. So today we want to discover, okay, what the most important thing here. We need to know that many people think that healthcare has too little data. But actually, the opposite is true. Healthcare is one of the biggest, the largest producers of data in the world. Look around this slide. You will see that every patient generates data from many different sources: hospitals, clinics, medical imaging, wearable devices, mobile health apps. Every one of these contributes enormous amounts of healthcare data. The challenge is no longer collecting data. The challenge is making sense of it. I like to describe healthcare today with one sentence. We are data rich, but insight poor. Having more data does not automatically lead to better healthcare. We need to transform data into meaningful insights, and that brings us to the next slide. Okay, many people think data and intelligence are the same. Actually, they are not. Let's follow the journey shown in this diagram. You can see in the middle, there's a diagram there. At the top, we have data. The raw data that consists of blood pressure, laboratory reports, medical images, heart rate measurements. And when we organize this raw data, they become information. Okay? And when we connect information together, we gain knowledge. Then AI analyze that knowledge to discover patterns that humans may miss, that become knowledge intelligence. But notice something very important here. Look at the bottom of the diagram. The final step is not AI. The final step is better outcomes that produce from better decisions. Because we should understand that AI does not save lives. Doctors save lives. AI simply helps doctors make better decisions. That is why I said that data does not save lives, better decisions do. Okay, go to the next slide. Let me use a very simple analogy. Imagine you have the world's most advanced sports car. Okay, without fuel, okay, it cannot move. AI is exactly the same. AI is incredibly powerful, but without high quality data, it cannot learn. Every prediction, every diagnosis, every recommendation, it depends on the quality of data used to train it. This is why big data is often called the fuel of AI. AI cannot stand alone. AI needs data to massage the data to give the information to make a better decision. But here is another challenge. Today, much of the fuel is trapped. Some data are inside hospitals. Some are inside clinics. Some are in the pharmacies. Some are on our own mobile phones. So the fuel actually exists, but it is simply disconnected. So the next question becomes, how do we connect all these different sources safely and securely? The answer is not AI. The answer is digital platforms. This is where digital platforms become the game changer. So we need to think how digital platform as the bridge that connects the entire healthcare ecosystem. Instead of every organization working independently, everyone can contribute to one connected healthcare journey. So I would like to ask you, if you could connect only one healthcare service first, which would you choose? You may type in the chat room. I would like to see which organization that you think it will connect first. Anyone can type in the chat room. I couldn't see the answer in the chat room. Okay.
Perhaps you need to repeat the question.
Oh,
Dr. Awanis.
okay. Okay. So my question is, if you could connect only one healthcare service first, which would you choose? Either it is hospital, clinic, lab, or anything that you see in the slide. Okay, Siska answer hospital. How about the others, the audience? Okay, okay, to answer hospital. So never mind. You made that because you think that it start with hospital, or maybe they think start from the lab or pharmacist because you already took the medicine from the pharmacist. But actually, there is no single correct answer. The real value comes from when everything is connected. Here we call it as an ecosystem. So now we have connected the data. The next question is, how does AI actually learn from it? Okay, next slide. Okay, many people think AI is magical. Actually, AI learns in a way that is surprisingly similar to humans. Imagine a young doctor on the first day at work. After treating 10 patients, his experience is still limited. After treating 10,000 patients, he began recognizing patterns almost instinctively. So AI works in similar way, but instead of learning from experience, it learns from data. So the key point is we need a ton of data, big data. And from the left to right, we can see the healthcare records, laboratory results, wearables, medication history. These become millions of patients' records. From this record, AI learns patterns. Then AI can do three important things. First, predict. So AI can predict who is at the risk. Second, AI can detect. Can we identify disease earlier? Third, recommend. But what might be the best treatment option? I want everyone to remember one very important point: who makes the final decision? Yes, the doctor. Always the doctor. AI supports clinical judgment. It does not replace it. That is why the goal of AI is not replacing healthcare profession. It is helping them make better decisions. Okay, next. So we can see the future is actually already here. AI is no longer experimental. It is already supporting healthcare in many countries. So AI in action, transforming healthcare today. Let's look at these four examples. We start with prediction. AI can analyze thousands of clinical sickness and identify patients who are likely to deteriorate before obvious symptoms appear. Imagine receiving treatment hours earlier instead of hours later. Those few hours could save a life. Second, we go to the detection. In medical imaging, AI works like a second pair of expert eyes. It helps radiologists detect disease earlier and reduce the chance of missing important findings. And third, personalized care. Every patient, we know that it is different. So AI helps doctors recommend treatments based on each patient's unique medical history and also on the characteristics. And lastly, automate. Automation, this is often overlooked. Doctors spend far too much time on paperwork, so AI can automate documentation and administrative tasks. That means healthcare professionals can spend more time doing what humans do best. I always remind people AI should automate paperwork, not on the human compassion. Okay, next slide. One patient, one connected healthcare journey. Okay, now I want to show you what happens when all these technologies work together. Remember the father we talked about earlier? Now I would like to introduce another patient, Mr. Lim. Mr. Lim is 68 years old. He lives with diabetes, hypertension, and heart disease. Like many older adults, he wants only one simple thing: to stay healthy enough to enjoy life with his family. Every day, his smartwatch records his activity, glucose sensor monitors his blood sugar. Most days, everything looks normal. But one day, something changes. Not one dramatic change, but these small changes. His heart rate increase, his activity decrease, his sleep becomes poorer. Individually, these changes seem insignificant. They actually form a pattern here. AI, we can see that AI recognize the pattern and alert his healthcare team. So this is when the ecosystem of healthcare connected, it will pass the information from one phase to the other phase. So number 4, if you look at the figure at number 4, AI recognize the pattern and alerts his healthcare team. The doctor reviews the information through a teleconsultation. His medication is adjusted and his condition improves because has the personal teleconsultation with the doctor. So, most importantly, the message that I want to send it here, Mr. Lim never needs emergency admission. What is the lesson? Was it the smartwatch that saved him? No. Was it AI? No. Was it the doctor? Not alone. It was the combination of big data, digital platforms, AI, and healthcare professionals. This is what we call smart healthcare. So this is the future that we want. Next. Okay, next slide. Okay, we see there is the pillar here. Many organizations believe smart healthcare begins with technology. Actually, the technology is only part of the solutions. Look at this building or this house. If one pillar collapses, the whole system becomes unstable. The first pillar is people. Technology succeeds only when people are ready to use it. The second is data. Quality data creates quality decisions. The third is technology. Platforms must be secure, reliable, and interoperable. And the fourth is trust. Without trust, people will not share their data. And without data, we know that AI cannot learn. So finally, the leadership. Digital transformation is not an IT project. It is an organizational transformation, and underneath every pillar is collaboration. Hospitals, universities, industry, government, technology companies, no single organization can build smart healthcare alone. So I would like to finish this session only for this slide with one question. Looking at these 5 pillars, which pillar do you think is the biggest challenge in your own organization? Is it people, data, technology, trust, or leadership? And again, there are no wrong answers. Every country is facing this journey differently. Like Malaysia, some people afraid with the data will be revealed to the public. So it needs to have the security. The trust is there. Okay, Mr. Farid, next slide. So far, everything sounds exciting, but let me be more realistic. Building smart care is not only about innovation. It is also about responsibility. Technology, we know that it moves quickly. Trust, that's much longer to build. And unfortunately, it can disappear overnight if we don't have that trust, and we know that if our data been revealed public and the security can be hacked. So let's we look at the 4 important challenges. Number 1, on the privacy and security. Patients are willing to share their data only if they know it is secure. It's also like internet banking, right? If you look at the old people, they still not believe in the internet banking. So same goes here because of the data. But for us, like I'm not really young like you, the audience, okay? But I believe that for the new generation, they love their smartphone because all the data inside here, we can do the transaction easily. So for the privacy and security, patients are willing to share their data only if they know it is secure. Healthcare organizations therefore need strong cyber security, clear governance, and responsible on the data management. Second, on the interoperability, many healthcare systems still cannot communicate with one another. So if systems cannot exchange information, connected care simply cannot happen. And third, responsible AI. AI learns from data. If the data are incomplete or biased, the recommendations may also be biased. So finally, people and change. Technology is often the easiest part. Changing habits, changing culture, and helping people embrace new ways of working actually is much more difficult. Okay, so the next slide.
Pardon, Dr. Awanis, you have 5 minutes left, so I recommend you to be fast.
Okay, thank you, Mr. Farid. Okay, so we have a quick trip around the world. Let's look at the 3 inspiring examples here. Singapore. Singapore has built a national electronic health record that connects public healthcare providers. Their vision is simple: one patient, one health record. Estonia is another remarkable example, which is nearly all healthcare providers use digital health record. And for the UK, the United Kingdom has been actively evaluating AI to support clinical services, including medical imaging. Notice the word support, the clinician still makes the final decision. So although this country have different healthcare system, they share the common ingredients: connected digital platforms, strong governance, and the patient-centered care. Okay, next slide. Okay, the future of smart healthcare. I think I can end to this slide become the last slide. Okay, so I believe healthcare is moving from treating disease to preventing disease. That is a fundamental shift. So let's look at 5 trends. Okay, predictive care. Instead of waiting until someone becomes sick, AI helps us identify risk much earlier. Preventive care. Okay, second, preventive care, helping people stay healthy rather than only treating illness. Personalized care, providing the right treatment for the right patient at the right time. Care beyond hospital walls. Healthcare is moving into our homes through wearables, remote monitoring, and telehealth. And finally, learning health systems. Every patient interaction becomes an opportunity to improve care for the next patient. Okay, so this is I can say the last slide. What I want to recap here, if you all is if you forget everything else from today's presentation, okay, because I'll talk too much, okay, I want you please remember these 3 messages. First, I want you to remember big data is the foundation. Without quality data, AI cannot learn. Second, digital platforms are the connector. They bring together people, systems, and information. And lastly, artificial intelligence. We know that AI is the accelerator. It transforms connected data into insights that support better decisions. Notice something? The center is not technology. It is a better healthcare. Technology become the enabler. Okay, with that, I would like to thank everyone for this session and be with me for the 30 minutes. And I wish you a wonderful webinar and I look forward to our discussion during the Q&A session. Thank you.
Thank you very much, Dr. Awanis, for your insightful presentations. Now we have the next agenda. It's our next speaker. We have a third speaker, Professor Alia Al-Akrawi, is a full professor at the Department of Physiotherapy, School of Rehabilitation Science, University of Jordan. She holds a PhD in Rehabilitation Science from University of Pittsburgh, United States of America, and has authored more than 70 publications in peer-reviewed journals and books. Alongside several registered patents in rehabilitation technology, she has served as president of the Jordanian Physiotherapy Society as a board member and chair of the Education Committee at the World Physiotherapy. Her presentation today is entitled Transforming Rehabilitation Services Through Innovative Technology and Evidence-Based Physiotherapy in the Digital Era. Please welcome Professor Alia Al-Akhrawi.
Thank you so much. Thank you for University Aisha Surakarta for giving me the opportunity to talk today about the technology. So I will talk today about research studies that I have been conducting in Jordan and involving the technology into rehabilitation. So I hope you enjoy these studies. So talking about technology revolutionizing physical therapy is very important since technology is now rapidly transforming our physical therapy and rehabilitation performance. Okay. Oops, I'm sorry.
Pardon, Prof. Alia, we can hear your
Oh,
voice.
I'm sorry. Okay. So I will go back to the previous slide and continue. Yes. So again, here I'm talking about the technology and how it is really revolutionizing healthcare system and specifically physical therapy and rehabilitation. And I was talking that technology is rapidly transforming our physical therapy rehabilitation. It also provides innovative tools to enhance our patients' care, also accelerate recovery, so increasing the time of recovery for our patients and also improve the outcomes. Regarding technology, it's various. There are many types and techniques that you can use from technology and invest them into our rehabilitation, and they are like virtual reality to mobile applications and even AI. Now we're talking about AI as well. Um, since we are now introducing the technology into our physical therapy, this also highlights if there is any limitations in the traditional physical therapy that we are performing in everyday rehabilitation. Actually, yes, there are some limitations that were found in our traditional physical therapy rehabilitation. For example, the limited access, because traditional physical therapy can be expensive and sometimes time consuming and make it is inaccessible to many people. For example, I went to Indonesia, so I know how far it is to go from one clinic or from one city to another. For example, in Jakarta, it's so there is a heavy traffic there. So if there is a way of doing physical therapy sessions without the need to go into traffic, that would be really beneficial. Also, the lack of personalization, because traditional physical therapy approaches often lack personalized treatment plans and can be maybe inflexible to individual needs. So with the introduction of technology and AI, maybe we can have some personalized treatment. Also, the traditional physical therapy is somehow subjective, specifically in the assessment of our patients. So, like the most of our assessment tools are subjective, and this can lead to inconsistent and unreliable measurements of progress. Therefore, using the technology in the assessment specifically would provide us with more accurate data, and of course, this will improve our plan of treatment and outcome. Also, there is some limited engagement sometimes in the traditional physical therapy. Like it is somehow boring for our patients to repeat all of these exercises again and again. So it's called monotonous and repetitive, leading to reduced patient engagement, motivation, and also adherence to exercises, especially when we give them home exercise program. Therefore, introducing technology in our daily physical therapy treatment would really be exciting. First of all, you can use virtual reality, and reality can be immersive. And what we mean by immersive, it's like the patients are immersed actually into virtual reality games, or they are called scenarios. So here actually virtual reality creates engaging and interactive environment for patients to practice exercises and regain lost functions. And again, here we're talking about enjoyable treatment, which will motivate patients, making exercise sessions more fun to them. For example, the optokinetic stimulation, as you can see in this picture here, is one of the important here, okay? It's one of the important treatment ways for people with vestibular disorders. So using, for example, these optokinetic stimulation and integrate these videos into virtual reality goggles here will stimulate patients to practice complex movements in a safe and controlled environment. And this will improve motor skills and coordination in those patients. Also, another example is using mobile applications for patients' engagement. Here, actually, also you can use personalized programs in the mobile applications. They can provide customized exercise plans for each patient that is different from another patient. It's nice that it gives our patients the reminders to do their exercises at home. It also can be more difficult. They can progress from easy or simple exercises to more complex and difficult, which promote patients' adherence and motivation in performing those exercises. Also, for the mobile application, it's real time. It's beneficial because it provides our patients real time feedback, because some applications utilizes sensors to monitor patients' movements, and they provide real time feedback on form and technique. So if there are some sensors that they can use in the application, then the app will tell the patient if they are doing or performing the exercises in the correct way or not. So this is also another addition of using applications as technologies in our rehabilitation. Also, the enhanced communication. Applications actually facilitate communication between the patient and therapist. Why? Because all of these feedback will be sent to the therapist, and then there will be some communication between the therapist and the patient, talking about their adherence, their performance. All of these information can be communicated later with the therapist. So this will allow actually for convenient appointment scheduling and even progress updates. Another type of technology that I have been using in Jordan is the TDCS. This is called transcranial direct current stimulation. This actually electrical stimulation to the brain is safe. So it is basically it is non-invasive stimulation. It uses weak electric current to stimulate specific areas of the brain, which will enhance neural plasticity and promote recovery. And this specific device actually that I brought from Spain is an HD electrical stimulation to the brain, which is really useful for our patients again to promote neuroplasticity, which is very important in our neurological patients. Also, it is very nice to use it in neuro rehabilitation, because TDCS here has shown a promise in treating various neurological conditions, including stroke, for example, brain injuries in general, and even Parkinson's disease. Also, this technology improve motor function. There are several studies that reported improving motor functions using TDCS. So by stimulating specific brain regions here, TDCS can enhance motor function, reduce spasticity, for example, in people with upper motor neuron lesion, and also improve their balance and coordination. So, what about technology-driven assessment? As I mentioned, one of the limitations of traditional physical therapy is the subjective assessment. So here, if you want to use technology into assessment and get some accurate and detailed assessment results from your patient, then you can use it, for example, for gait analysis. There are several technologies nowadays that use motion capture systems that provide objective measurements of gain parameters, and also it identifies movement impairments, and also it guides treatment strategies. So this is one of the important areas in our patients to analyze their gait in a very scientific and objective way and get specific numbers and results in order to inform our treatment plan, and also compare the assessment between baseline and follow-up for our patients and show the improvement in a digital and technological way. Also, we can use technology in assessing the strength and endurance of our patients. So here we're talking about digital dynamometers and wearable sensors that accurately measure muscle strength and endurance and allow for personalized treatment programs or training programs. Also, virtual reality can be used as an assessment tool. So, for example, VR stimulations allow objective assessment for balance, coordination, and even cognitive functions, of course, in a controlled environment. So we arrived here now, the robotics also. So technology enhanced interventions are used heavily nowadays. So for example, robotic therapy is the future actually of maybe the current and the future rehabilitation. For robotics, actually, it provides assistance and feedback for repetitive exercises, improving muscle strength, coordination, and even function in general. So having a robot, for example, with the patient at home will help them in repeating those exercises, making sure that the patients are doing exercises in the correct way, and also helping them maybe in doing like active assisted motion, because sometimes they cannot do it by themselves. Also, using virtual reality games or scenarios are also important in the interventions of technology or into rehabilitation, such as like engaging and motivating patients to perform rehabilitation exercises. Of course, this will improve their motor skills and cognitive functions. What about augmented reality applications? Also, there are several applications that use augmented reality in order to improve patients' functions. So, for example, overlaying digital performance into the real world, providing patients with guidance and feedback during their rehabilitation. Talking about big data and data-driven decision making, of course, the data should be accurate in order to be able to interpret these data in the correct way. So data collection also has been technologies have been used for the data collection part. So wearable sensors, again here, mobile applications and virtual reality systems, all of them were used to collect real-time data on patients' progress and performance. And this is something really important, when you collect data that are real-time. So in the same time that your patient is performing any task, all of these data will go to a software in your computer, and you can analyze these data immediately when you are still looking at your patient. Performing these tasks is really a very important step in rehabilitation. Also, you can use data analysis. So there are some sophisticated algorithms and machine learning models that are used to analyze data, to identify patterns, and even predict future outcomes. What about personalized treatment? Yes, you can use technologies and data insights to inform personalized treatment plan, tailoring also the treatment plan for your patients. Um, is there any challenges in using technologies for rehabilitation? Yes, of course. We face several challenges actually in introducing technology into our daily rehabilitations for patients. For example, the first one is the cost. You know, everything in the beginning, usually it is expensive. So integrating new technologies can be expensive to certain clinics and hospitals, requiring, of course, investment in equipment and also training. So you are purchasing the equipment, and at the same time, you need training for the staff who are using these equipments. Also, the other challenge that was mentioned by previous speakers is the privacy. So, of course, patients will be afraid that their data will be shared in an illegal way somehow. So, data privacy and security are paramount here. We need to ensure that the patient's data is preserved and it is really protected. Also, you know, ethical dilemmas here also appear. So, for example, careful considerations must be given to the ethical implications of using technologies into patient care. It's very important to make sure that ethical considerations are taken seriously and carefully when you use technologies. Also, access. Sometimes it is important to ensure equitable access to these technologies for all patients, regardless of their socioeconomic status, because we mentioned in the first challenge that these technologies are expensive. So in order to make it really fair, it's important to make sure that all patients have access to these technologies. Is there any future of technology enhanced physical therapy? Yes, of course. The future of physical therapy is bright. I believe in that. And rehabilitation is the key for several diseases nowadays. With continued advancements in artificial intelligence, AI, robotics, and wearable technologies, all of these advancements will lead to even more personalized and efficient and effective treatments, which is our ultimate goal. You know, our ultimate goal is to improve the quality of life in our patients. And if technologies can be contributing into achieving our main goal, this would be even better. So yes, ultimately we need to improve patients' outcomes and transforming this field and improving their quality of life. To just give you some examples from my research here, this is, for example, the TDCS study this is the protocol that was published in 2022. It's the effect of TDCS on sleep in athletes. It was a protocol for randomized controlled trial that we are still conducting. So we use TDCS here to improve sleep quality in athletes. And since we just had the World Cup. Okay, so sleep disorders in athletes and players is a big problematic way, actually, especially when they move from one country to another with different time zone. So yes, I've been using TDCS in improving sleep quality in athletes and even in also another study in people with multiple sclerosis. So these are the study parameters. The study is published and it is open access. You can get it for free. As you can see, the current is very small. The intensity is 1.5 milliampere, and we use it 3 times a week for 2 weeks only. And each session actually takes 20 minutes for for the athlete here to have. Um, um, and the current was delivered for 30 seconds in control group. So we had a control group as well. The outcome measures that we used in this study also included technologies. So the Actigraph watches, if you have heard of it, it's made in the US. It assesses the sleep quality in real time. So we give it to our patients for 2 weeks. So during these 2 weeks, actually, it assesses their quality of sleep in a way that doesn't interfere their sleep. So they wear it as a watch in their wrist, and it will give all of this information to us. Of course, we included other subjective measures here, like questionnaires, in order to collect data about sleep. But the main objective outcome measure that we are using here is Actigraph watches, which is a technology-based wearable device. Until now, we have only 18 elite athletes that have been recruited. They're young. The age is 21, the mean age. Males and females were equal, so 50% of each. The years of sporting practice, the mean age was the mean years was 6 years. And we included boxing, judo, and karate players. These are, the data. So between baseline and after treatment, we compared the assessment using objective measures and subjective measures. And until now, we're not getting some significant differences. Another technology that I want to talk about quickly is an application, on a tablet application. And I want to talk about the objective assessment of gaze stabilization exercise in people with multiple sclerosis using an application called VistAid. Also, VistAid is an application that is used in the US. As you can see here, it's a tablet-based platform. It assesses various metrics of gaze stability and performance during the VOR exercise in the rotation plane. Yaw plane, it means head rotation. So participants here were instructed to move their head approximately 30 degrees to the right and left from the target placed 1 meter in front of them on the tablet. The exercise was performed under static plane and complex backgrounds and also optokinetic visual backgrounds. So I will show you, if it works quickly, how this application. So she's my master's student. So she's focusing on the target and moving her head 30 degrees to the right, 30 degrees to the left, as you can see. Here is the X. So she's focusing here on the X. This is a plain background, and these are complex backgrounds with different colors. What this application actually does, it is implemented in a tablet base. The tablet has a camera, facial and eye recognition is used to analyze accuracy of the head and eye movement. It's really nice. It provides you with, again, detailed information. So here is the gaze accuracy and the head speed compliance. As you can see, here is head motion compliance. It provides you with a graph of the patient's head motion compliance and also with the eye gaze compliance. Also, it asks after each condition about the symptoms and perceived difficulty in performing this task. So again, this is the implication for rehabilitation. It is objective assessment. Also, it gives the patient different challenges during performing this task. The last study that I want to talk about here is the effectiveness of using virtual reality in people with triple PD. Actually, triple PD is persistent postural perceptual dizziness. It is a chronic vestibular disorder characterized by persistent dizziness and unsteadiness or balance problems, often triggered by motion or visual stimuli. In
Burden, Prof. Alia?
5 minutes,
Yes, 5 minutes left.
I will be done by then.
Okay.
Thank you. Thank you. So for this study, our main objective is to assess the effectiveness of a specific exercise program with virtual reality compared to vestibular rehabilitation therapy, which is the traditional physical therapy. As you can see, also, I will show you a quick video here. These are the exercises that we give to our patient in the beginning. So in the beginning, they were not using any technologies, just a traditional physical therapy exercises, focusing their eye on an object. Sometimes the object is static, it's not moving, and then the object is moving. So different exercises that we give to our patients with vestibular disorders, as you can see. So this is called VOR cancellation. Okay, until now we're not using technology in the beginning. Okay, so here for their balance, just to some like strategies in their hip and ankle. Okay, it's not the best strategy, but we tried. Yeah, this is ankle strategy. Okay. So yeah, now we are, introducing virtual reality. So in the beginning, actually, they are just sitting in a dark room looking at those optokinetic stimulation videos. So these are the optokinetic videos. So we started from sitting position, then standing position, then we introduced virtual reality goggles. And even using the goggles, we also ask them to stand on different backgrounds. So from solid background to foam, the balance foam, and to other, and the trampoline, okay? So in this study, actually, we found some improvement. So within a group changes of the experimental group, patients had significant improvement in all outcome measures that we used, and these outcome measures were maintained up to 1 year after the end of the treatment. These are the outcome measures that we use with several outcome measures, including, subjective measurement of dizziness, vertigo, quality of life, balance, and objective ones as well. So what we found actually that the use of virtual reality goggles here improved their balance and reduced their dizziness. Also, it enhanced their mental health. So psychologically, they got better. And also, the nice thing here is to maintain our improvement after 1 year. Thank you.
Thank you very much, Prof. Alia, for your presentation. It's wonderful topics, actually.
You're welcome.
Now we move on to discussion session or Q&A session. To all the participants who have any question to our speaker, feel free to give ask your question to the chat, or you can raise hand also. So actually we already have one question from our student, Cesar Salva Afifa, for Dr. Awanis. The question is, AI is becoming increasingly capable of supporting clinical decision making. How do you see the balance between AI recommendation and clinical professional judgment evolving in the future? Perhaps one by one question. Please, for Dr. Awanis, you can answer the question.
Okay, thank you, Salwa. That's a great question. Okay, actually, AI, we know that it will not replace doctors or healthcare professionals. Instead, we know AI as a very smart assistant. AI really good at analyzing a huge amount of data, big data, in a very short time. So AI, again, when we recap to the slide, it can detect patterns, predict risks, suggest possible diagnosis, but AI doesn't know the patient personally. It doesn't understand the patient's feelings, family situation, or personal preference. That is why the final decision should always be made by the doctors or healthcare professional. So I believe that in the future, doctors will work together with AI. AI become assistant, and AI will provide useful recommendations, while doctors will use their experience, clinical judgment, and compassion to decide what is best for the patient. So the future is not AI versus doctors. So we want to see the smart healthcare. The future is AI working together with doctors to provide better healthcare. Okay, thank you.
Thank you, Dr. Awanis, for your answer. Let's move on to another question. I think Mr. Trivibowo, time's yours if you have questions. I'm Trivibowo. Please feel free if you have any questions to our speaker. He has trouble in the techniques. Okay, you can give the question in the chat box. So let's move on to Siska Nitias. If you have any questions, feel free to be asked into our speaker.
Okay, thank you, Professor. Thank you, Pak Farid, for the time. Okay, I would like to ask for each professor. There are for Professor Aliza, Professor Dr. Awanis, and Professor Alia. So I have one question. The first is for Professor Aliza. Professor Aliza, can you hear my voice? Okay. Or maybe
Yes.
yeah. So I have a question for you about many digital health innovation demonstrate excellent clinical outcomes during pilot projects, yet only a few achieve large-scale adoption. From your experience, Professor, what are the key elements that transform a promising innovation into a sustainable healthcare business model with a system-wide impact?
Okay. So please.
Okay, Professor, there is my question for you. So the second question is for Professor, Associate Professor Dr. Awanis. Throughout your presentation, you emphasize that successful smart healthcare depends not only on AI, but also on high-quality data, digital platform, trust, leadership, and collaboration. Professor Dr. Awanis, in your opinion, which of these elements is the most critical for achieving sustainable digital transformation and why? And then the last question is for Professor Alia. Professor, while technologies such as TDCS, virtual reality, and AI-based assessment have shown great potential in rehabilitation, what do you think is the biggest challenge in the integrating these technologies into everyday clinical practice while ensuring they remain evidence-based, affordable, and also patient-centered? Okay,
Thank you
that's
for
all
your question.
my
Yeah, actually, I mentioned the three main challenges or four challenges. So the main one is the cost. Sometimes having these technologies at home with the patients is really challenging. They cannot afford buying these technologies if they want to use at home. And even, clinics and hospitals, like physical therapy clinics, maybe they cannot afford also buying those technologies in order to provide patients with objective assessment and also intervention. So maybe this is one of the main challenges. I would add actually tech problems. So sometimes high tech has, any technology has its own faults. So as physical therapists or as people who work in the healthcare sector, maybe our knowledge in softwares and technologies is limited. So we need to learn more how to run those technologies, and if there's any problem, to be able to solve it without bringing IT people or even engineers. So these are the main two technologies that I faced in using these technologies in our research.
Okay, thank you, Professor Alia, for your answer.
Okay, thank you, Alia. Perhaps next can who's the first to answer, Dr. Awanis or Prof. Aliza?
Okay. Thank you so much, Siska, for the question. Sorry if I look here and there because I have my screen here and my camera is here. All right. Basically, having a good idea on paper is easy, right? But the application is the hardest part. So everything that happens after that turns into an idea that is something that has actually happened for years. That is the most difficult part. People have to actually change the way they work just for the new tools. And then if a hospital busy with a fancy new apps, but everyone keeps doing their job exactly the same way as before, so nothing really changed. So you just added one more screen for a tired nurse to check, but the real impact only happens when the leaders are willing to say, yeah, okay, we are going to do this differently now, not just here's a new gadget. So it goes back, it's related to what Dr. Awanis presented in her slide. Is something to do with leadership. All right. Again, it's about the human touch. A lot of great health apps get stuck because nobody bothered to measure whether they actually help or whether insurance will pay for them until almost too late for them to discover that. For example, in Germany, I came across one research when I did my paper. They let new digital health tools get paid for early while still collecting proof they are working on it. So that early proof is what keep things alive along to the matter itself. So if you build something only for people with smartphones, like I mentioned just now, it will only ever help people with smartphones and good internet. So we have to plan from the very start for if you have grandmother in the village who needs someone to sit with her and help her to use it, right? The community health, who is going to help her? Is it going to be the community health volunteers? Do you have a system that is going to support the people who are in the rural area? So these are example that kind of help human to build from the beginning till the end. And again, it's about trust. All right, no one uses a health apps that they don't trust, no matter how smart is AI, because AI is actually come from human being, and trust doesn't come from a nice advertisement. It comes from the actual giving communities and patients a real say in how the thing is run, not just asking your opinion once and moving on just like that. So the honest truth is that you can be brilliant, you can have a great apps, no trust fails. It really works, but again, it needs to have a good governance, a good system, good engineering, all right, so that we can actually accommodate all the stakeholders that are involved in this health, digital health.
Thank you, Prof. Aliza. I think it's time for Prof. Dr. Awanis. You can.
Okay. Okay, thank you. Thank you for the question, Siska. It's a great question. Refer to the building smart healthcare. We know that the 5 essential pillars start with people, data, technology, trust, and leadership. So look at this building. We know that actually when one pillar collapses, so everything, the other pillars also will be collapsed. It's not strong enough. So if I had to choose just one pillar, I would say people. The reason is simple. Technology doesn't improve healthcare by itself. Okay, we know that technology in the third pillar. Data doesn't analyze itself. AI doesn't make the final decision. So who make all this happen? The answer is people. So healthcare professionals use their knowledge and experience to care for patients. And we know leaders provide the vision as Dr. Aliza said just now. Technology experts develop the systems. Patients also play an important role by engaging with their own health. So without people, the other four pillars cannot function effectively. However, I would also like to emphasize that there isn't really a most important pillar. These five pillars are like the pillars that supporting a building. If one pillar becomes weak, the whole structure is affected. Okay, so that's all. Thank you.
Thank you, Dr. Awanis, for the answering the question from Mrs. Ka. I think it's enough, Ms. Tiska. Okay, let's move on to another audience. Mr. Trivibowo, can you start to
All right. Assalamualaikum, Prof. Alia. My name is Muhammad Triwibowo from Universitas Aisyah Surakarta. I want to ask a question for Prof. Alia. So, many rehabilitation technologies, so promoting result in research setting. What do you think are the biggest barriers to translating this innovation into routine clinical practice?
Thank you. Thank you for your question. Maybe, one of the challenges that I mentioned is the cost, but also I would like to add also training on those technologies. So it's very important for healthcare providers in general and physical therapists in specific to be able to train, to have the appropriate training on those technologies for the assessment and treatment of patients, also to be able to be creative in like designing a specific treatment plan for your patients. So the idea is that technologies are available and they are abundant. There are many things that you need to choose from, but you need to be creative and be able to choose the correct technology for your patient based on evidence. That's the nice thing about it, that you can read articles, go back to the literature, and choose the best for your patient. So maybe this is one of the barriers. It's very important to know more about technologies and like the technologies that are used with specific patients. So when you go to the clinic and see your patients, first of all, you need to identify the population that you are treating. Afterward, maybe find evidence about specific technologies that can be used with your patient. And here you can be creative in designing an individualized treatment for your patient. So I hope I answered your question.
Thank you,
Thank you.
Prof. Alia. Is it okay? Is it answering your question, Mr. Trivibowo? I think it's already answering to Prof. Alia. Let's move on to another audience. Pepi, feel free if you have any questions. Pepi, okay. Can you unmute your microphone?
Hello, sorry, has my voice been heard?
Yes, loud and clear. Okay, pardon, your mic is being mute again. Can you unmute your mic?
Hello.
Yeah, okay, clear.
Thank you, Shelly. Let me introduce myself. I'm Feby Puspita Sari from Aisyah University Surakarta, Bachelor of Medicine Study Program. Professor, as Mr. Awani, you emphasized that data is not intelligence. In your opinion, what are the most critical steps healthcare organizations should take to transform healthcare data into actionable clinical intelligence? Thank you.
Sorry, actually, I couldn't hear your voice clearly. Can you repeat your question, or you may type in the chat room? Uh, can you repeat the question, or you can type in the chat room so that I can reply?
Okay.
Okay.
Tap in the chat room. You emphasize that data is not
Oh,
intelligent.
okay. Okay, thank you. I received your question here. Okay, so yes, I mentioned that data is not intelligent. Data only becomes valuable when we can turn it into better decisions. So in my opinion, there are 4 critical steps here. First, we need to collect high quality data. So if the data are incomplete, inaccurate, or outdated, AI and analytics will not produce reliable result. Okay, like we often hear or say that garbage in, garbage out. Okay, so second, about the connection, the data. Patient information is often stored in different hospital, clinic, laboratories, and also sometimes you went to the pharmacies. So if this system cannot communicate, healthcare professionals only see part of the patient story. And third, we need to analyze the data using AI and also the analytics. This is where we move beyond simply storing information. So AI can identify patterns, predict risks, and provide clinical insights, which is can support, can assist healthcare professionals. So lastly, how you want to turn insights into action, which is intelligence, only creates value when it helps doctors, nurses, and also the teams to make better decisions that improve patient outcomes. Okay, so is it clear, Feby? Thank you for the question.
Okay. I think with answering, so the response of baby is positive, Dr. Awani.
Okay, thank you.
Okay, let's move on to another questions. I think I'm choosing the other chat question from the chat box from Prof. Afwiri from Rizka Savitri. He asking, good morning, Prof. Afwiri. Thank you for your insightful presentation. My name is Rizka Savitri from Universitas Asia Surakarta. I have one question. How do you see Phase 8 being integrated into routine clinical rehabilitation, especially in low and middle income countries where access to advanced rehabilitation technology is still limited? Okay, Prof. Alia. Time's yours.
Thank you for the question. So, as I understood, it's about the limitation of data getting from the technologies, right? Well, that's correct. Sometimes the data, like for example, with the application, we really had to ask the help of engineers in order to understand the data, like to be able to interpret the data into health understood data. So yeah, I totally understand the challenge that sometimes we face, specifically with the data gained from technologies and devices. So here you need to be careful in in uh, in getting the data out of these technologies, and at the same time also be able to interpret these data in the correct way, so that you go to like further steps, for example, telling the patients about these data, and also designing your treatment plan based on these data. So yeah, this is one of the challenges, is interpreting the data in the correct way after assessing your patient, or even after treating your patients using these technologies. Did I answer the whole question? Is that good?
I think it's answering the question
Okay,
from Rizka Safitri.
perfect. But thank you for very, very good question. Thank you.
Thank you, Prof. Alia, for the answering the question. Okay, let's move on to another questions. I move on to uh, let me choose. Prof. Aliza, are you still here? There is a question from Safa Dilat Marwani. Assalamualaikum warahmatullahi wabarakatuh. Please allow me to introduce myself. My name is Safatila Mawarni, a student of the Bachelor of Nursing program at Universitas Aisyah Surakarta. With your permission, Prof. Aliza, I would like to ask your question. The presentation suggests that digital scale is the only mathematical solution. Could there be a situation where expanding physical healthcare infrastructure is still more efficient than digital solution? How should policymakers decide the right balance? Thank you for the opportunity.
Okay, thank you so much for the question. Great question. And yes, absolutely, there are situations where building more physical infrastructure still wins. Taking COVID is simply digital tools work best for things like consultation, monitoring, and information. A doctor talking to a patient or tracking blood pressure over time and so on. But digital can't see a broken bone or delivery a baby or run an ICU. So if a rural area in Indonesia, for example, has a zero surgical capacity, no app fixes that, then you need an actual operating theatre and surgeons to go around. So a simple rule for policymakers is the bottleneck information access, or is it enhanced on physical care? So if it's the first, then we have to go for digital. It's cheaper and scales fast. If the answer is the second, then the policymaker needs to bring equipment, staff, and so on. So in practice, we can see that the smartest systems do both together. Use telehealth to triage and monitor. So the physical infrastructure like ambulance, hospitals, the doctors gets reserved only for the cases that truly need hands-on care. If it's not digital instead of physical, then it's digital protecting physical capacity for where it is irreplaceable. So then a policymaker, they need to look into these questions to make sure that everything is in the right balance. So I do hope that answer your questions. Safa, is it Safa?
Yeah, I think it's answering the whole question. I think. Thank you, Prof. Aliza. Okay, there is a lot of questions still in the chat box, but unfortunately, the time is ticking. So, thank you so much for the all speaker, for Professor Alia, uh, Professor Aliza, Dr. Awanis, for your time and your presenting topics. It's very honor for us to having you here in this event. Mm. And I'm sorry for the other audience who have already give the question in chat box who unable unable to giving to answering by the speaker because the limitation of the time. We have some gifts for you, Prof. Alia, Prof. Aliza, and Dr. Awanis. Is a certification of being a speaker in this event.
Thank you. Thank you so much. Have a good day. Bye.
Thank you
Thank you,
so
Assalamualaikum.
everyone.
Thank you.
Bye.
Thank you everyone for your attending and your participation for the first session. Now we move on to our second session. Our next speaker is Asita Rahmah Mutnawasito, Master of Physiotherapy, a physiotherapist and assistant professor at Universitas Asia Surakarta. She earned her applied bachelor degree in physiotherapy from Universitas Asia Surakarta, graduating as the best graduate of the program, and her Master of Sport Physiology with a concentration in physiotherapy from Universitas Udayana, Bali. Her clinical and research interests focus on geriatric physiotherapy and active aging, particularly balance impairments in older adults, fall prevention, and intervention that support mobility and functional independence. She has received research funding from Indonesia Ministry of Education for innovative work on low-cost senior fitness program and augmented reality guided exercise for older adults. Today, she will be presenting on the topic of advancing geriatric physiotherapy through technological innovation and evidence-based rehabilitation. Please welcome Asita Rahmah Mutnawasito, Master of Physiotherapy. Assalamualaikum, Ibu Asita. Welcome.
Waalaikumsalam, Mr. Farid. Can you hear me?
Yes, loud and clear. Please make yourself comfortable. Whenever you're ready, please go ahead. 30 minutes from now.
Yeah. Okay. Thank you, Mr. Farid. First, I will to share my screen. Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. My name is Asita. So this webinar, I want to explain about advancing geriatric physiotherapy through technology innovation and evidence-based rehabilitation. So the first, okay. Yes. The first, I want to show you about the demographic, the elderly in the world. So, the by data in 2030, approximately 1 in 6 people worldwide will be aged 60 years or older. The number of people in this age group is projected to increase from approximately 1 billion in 2020 to 1.4 billion by 2030 and 2.1 billion by 2050. So, okay, why has mobility impairment among older adults become a global concern? Because the elderly demographic, we have the division. So why this rapid demographic transition is expected to substantially increase the prevalence of age-related mobility limitation, functional dependence, and falls and disability, as well as the demand for the healthcare and rehabilitation service. So I would like to take you through how the human body changes, especially to the anatomy. So when we be the older, so how much do muscle mass and muscle strength decline with age? So the longitudinal heart study demonstrate that among adult at age 70 to 79 years, muscle strength decline much more rapidly than muscle mass. So the lower extremity strength decreased by approximately 3.4 until 4.1% per year in a man, and 2.6 till 3% per year in a woman. This means that strength loss occurred nearly 3 times faster than muscle loss. Therefore, sarcopenia should not be viewed simply as a loss of a muscle size, but rather as a complex process involving impaired muscle quality and reduced neuromuscular control. And the number 2 organ is a nervous system. When I'll be elderly, studies of the tibialis anterior muscle have shown a substantially related decline in the number of motor units, with approximately 39% fewer motor units by the age of 65 and 61% fewer individual aged 80 years and older compared with young adults. So why does muscle strength not decline immediately when the motor neurons are lost? Because the remaining healthy motor neurons undergo a complementary process is known as collateral renovation, in which they sprout new axonal branches, the reinnervate muscle fibers that have lost their original neural input. This adaptive mechanism helps preserve muscle mass and maintain force production despite the progressive loss of motor neurons. And the organ number 3 is a vestibular system and a balance decline. So when the older elderly, the Scarpa organ or vestibular ganglion is a collection of the cell body of primary vestibular cell. Does never receive every input from the hair cells in the semicular canal, utricle, and sacal, and transmit this information to the vestibular nuclei in the brainstem and cerebellum, where it is set integrated to maintain balance, gas stability, and postural control. So, histopathological study of 106 temporal bones from 75 individuals demonstrate a progressive age-related decline in the number of vestibular ganglion cells, with an average loss of approximately 75 neurons per year. The reduction was more pronounced in the superior division than in the inferior division of the vestibular ganglion, can make vestibulospinal reflex decrease. And then from all the functional elderly decrease, so can make any problem, which one is a false and a dependency among older adults. So this is a picture infographic illustrates how vulnerability in older adults begin with a frailty. The frailty is a critical early stage because it can lead to reduced mobility and increase a risk of falls. So over time, this condition might contribute to greater functional dependence among older adults and eventually create a substantial health, social, and economic burden. So this is this section. I have three point about the why the geriatric physiotherapy needs a lab. Geriatric physiotherapy must evolve to address the growing demand for rehabilitation associated with population aging, frailty, sarcopenia, and falls, and multimorbidity. Rehabilitation is success should focus on older adults' ability to move safely, to participate in a daily activity, and maintain independence. Technology can expand access, enhance monitoring, and support continuity of care without replacing the essential role of the physiotherapist, enabling rehabilitation service to become more preventive, integrated, function-centered, and by evidence-based. Yeah. This is design of exercise for elderly. So I want to show you the design. The program consists of the 5 types exercise. The first, balance. Balance and a functional text can improve stability, gait transfers, and a fall resistance. So number 2, there is a progressive strength. Progressive strength can build lower limb power for sit-to-stand, stairs, and mobility. And the 3 are aerobic capacity, enhanced endurance, cardiovascular fitness, and walking tolerance. So the 4 is their flexibility and mobility can support joint range, posture, and movement efficiency. And the number 5, exercise is education and self-management can promote endurance, safety, awareness, and long-term independence. So what the means is practice. Exercise remain the main evidence-based treatment component. Technology should supporting monitoring, progression, and adherence. So and then program should be individuals, progressive, and function focused. And then we have the 3 points about those matters. Those matters is like intensity, progression, and adherence should be plain documented and adjusted. And number 2 is a specificity matters is like the trend that exactly the person needs in a daily life, such as a sit-to-stand, walking, stairs, tools, task activities, and for recovery. And then number 3 is a participants matters. Goals should connect to the person, real life rules, activity, and environment. So this is exercise design for the elderly when the function is decreased. So there a balance training, so improve postural control and reduce risk of falling. Exercise example is like a tandem stand, a single leg stand, weight shifting, a stepping in multiple direction and turning 30 60 dual tasks and continuing while standing. And the strength training can example exercise like a sit-to-stand, step up, leg press, squat, heel raise, hip abduction, and resistance band exercise. So and the gait function training is example exercise like a gait training, obstacle negotiation, start training, turning and change of direction of functional tasks. And the aerobic training is exercise example is walking, stationary cycling, low impact aerobic classes, water aerobic, and flexibility mobility. Again, example exercise like a calf stretch, hamstring, a hip flexor stretch, and shoulder and thoracic mobility and trunk rotation. So about Education behavior strategy can fall prevention education, home safety advice, footwear advice, medication review, and goal setting and self-management. So you can use about those like a frequency, intensity, time, attack, and a volume. So can this evidence-based and show you for my screen. So this is conventional exercise. Yeah, these exercises are designed to prevent progressive functional decline in older adults. So preserve their physical capacity and independence and minimize the risk of loss. Conventional exercise-based rehabilitation can be enhanced through technological innovation to expand access, facilitate patient engagement, and support the effective delivery of physical rehabilitation service. So I want to show you about evidence-based practice. Yeah, this is evidence-based practice about technology combined with physiotherapy geriatric. The which one is the rehabilitation for chronic knee pain by Hinman et al. 2024. This is a result of physiotherapy. Telerehabilitation can be used as an alternative to or as part of hybrid care for medically stable patients who can use the technology and exercise safely at home and etc. So the following evidence-based findings support the integration of a technology into physiotherapy, like assessment, intervention, and rehabilitation process. Okay, this is example from the technology and combine the physiotherapy geriatrics. So the key question is how conventional exercise-based rehabilitation can be advanced through the integration of modern technology. So the following are several examples how technology innovation can be integrated into geriatric physiotherapy practice. This is technology innovation stack. The one, access. This is the rehabilitation and hybrid care model extends rehabilitation service into home and community settings. It's like example is video consultation, exercise guidance, and remote supervision. So this is like a wearable sensor for plates and motion capture system objectively measure physical activity, balance, gait, and clinical progress. How it works like a track movement and balance, one chip performs and monitor progress over time and etc. So I want to tell you about when the common technology and the physiotherapy geriatric, the value of technology lies not in the sophistication of the device, but it is ability to improve access, measurement, precision, patient engagement, clinical decision making, and continuity of rehabilitation with the replacing physiotherapists, clinical reasoning, or the therapy relationship.
We're done, Mbak Sita.
Okay. Yes.
5 minutes left.
Okay, I will be fast. So telerehabilitation from remote visit to hybrid care model. This is which common remote rehabilitation when statically scheduled in-person session according to each patient and clinical needs. Safe implementary of rehabilitation technology, including appropriate validation, governance, and professional oversight.
Okay, wait for a while. Let me replacing your position for presenting your PowerPoint.
So guys, okay. Okay, so guys, I will to this is the rehabilitation should not be understood merely as transferring physiotherapy visit and from the clinic to video-based consultation. Uh, as a more effective approach, a hybrid care which accompanies remote rehabilitation with strategic schedule in-person session according to each patient clinical needs. The safe implementation of rehabilitation technology, including appropriate validation, calibration, governance, and professional oversight, may be explored in leadership during a future occasion. And then I want to tell you about the key takeaways. First is evidence and technology with a purpose. Safety and equity are essential, and implementation is clinical leadership. So, in the end, in my presentation, the most critical consideration in telerehabilitation is that the rehabilitation team might be physical distant from the patient. Therefore, clear procedures must be established to manage situation in which an injury or other parts even occurs during exercise. Requires remote supervision protocol and the emergency response, a pathway, caregiver involvement, and criteria for escalation to in-person or emergency care should be developed to ensure patient safety through the rehabilitation process. So guys, this is my presentation ending enough. So thank you for your kind attention. So I hand it back to Mr. Farid. So Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for Ms. Asita of your presenting the wonderful subject topics. So now we move on to another session. We move on to fifth topics. Our next speaker is Sivya Rekawati, Master of Management, a lecturer in the field of economic and business at the Universitas Asia Surakarta. She completed both her bachelor and master degree in management at Universitas Muhammadiyah Surakarta, with her graduate research focusing on capital structure, dividend policy, and firm value. Her teaching areas included Introduction to Finance Management, Business Mathematics, and Introduction to Accounting. She will presenting on the topics of strengthening healthcare services through entrepreneurship, digital transformation, and sustainable business strategies. Please welcome Sivya Rekawati, Master of Management. Assalamualaikum, Miss Tivi. Uh,
Waalaikumsalam warahmatullahi wabarakatuh, Mr. Farid. Can you hear my voice?
Yeah, loud and clear. Whenever you're ready, please go ahead.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. My name is Civi Erikawati, and it's my great pleasure to welcome you to this international webinar. Our theme brings together three ideas that are almost always presented as an ambitiously good: entrepreneurship, digital transformation, and sustainable business strategy. My job in the next 20 minutes is to look at all three through a much less fashionable lens: finance. I want to argue something specific. These three pillars do not strengthen healthcare services on their own. They strengthen healthcare services only when they survive a financial test. So the question I keep returning to is not, is this innovative, but does this pay? When and to whom? Here is where we're going. I start with financial squeeze, why healthcare systems are running out of headroom, then how capital is flowing into digital health, and how sharply investor behavior has changed. The middle is the technical core, cost anatomy, the world value stream, and the appraisal tools, net present value, internal rate of return, and payback period. Then the evidence of return, a 5-year model, and stress tests. I close with financial instrument, a governance roadmap, and some open questions. The financial squeeze, let me begin with the constraint because everything follows from it. Demand is growing faster than the net revenue base that fund it, and three pressures are compounding at once. First, claims are outpacing premiums. Indonesia's national insurer recorded a claim ratio of 111.86% in early 2026, 32.73 trillion rupiah of claims against 29.26 trillion of premium revenue, a shortfall of 3.47 trillion rupiah. Second, households are absorbing the gap. 28.8% of total health spending is still out of pocket, roughly 175 trillion rupiah as of April 2026. That is opposite of what financial protection is meant to achieve. Third, the risk pool is shrinking. By February 2026, 58.32 million participants were inactive, 13.48 million in arrears, 44.84 million deactivated. Insurance works by cross-subsidy, and cross-subsidy weakens when the healthy stop paying in. Source by BPJS Kesehatan data reported by the Jakarta. Structure deficit. I want to dwell on this chart because it changes how you read everything that follows. The DAS's red line is break-even, a claim ratio of 100%. Above that line, reserves rather than income are paying for care. Look at the sequence: 104.72 in 2023, 105.78 in 2024, 107.69 in 2025, and 111.86 so far 2026. 4 consecutive years moving in one direction. That is not a bad year and not a business cycle. It is a design problem in the funding model. And not What tariff adjustment alone cannot do, you can rise your way out of this while the active membership-based contracts because you would be charging more to smaller pool. The implication is uncomfortable but simple. You cannot assume the payer will fund your growth. Efficiency gains have to be self-financed. Three pillars, one financial test. So where do our three pillars fit? Entrepreneurship gives us new service lines and partnership. Its financial question, can it raise capital and reach break-even? Digital transformation gives us record, telemedicine, analytics, clinical AI. Its question, does it clear the hurdle rate? Sustainable strategy gives us ESG discipline, resilience, and access to long horizon capital. Its question, is this cash flow durable? Notice the three arrows point to the same place. The finance function is the common gate. Every initiative, however clinically attractive, competes for the same scarce capital on the same terms, incremental cash flow, risk-adjusted return, time to pay back period. That is why I treat finance not as one pillar among three, but as the gate all three must pass through. Capital flows. The good news, capital has not disappeared. Global venture funding in the digital heart reached $29.7 billion in 2025. Comparing first half, global funding actually rose from 21.4 to 22.6 billion, and US funding from 6.4 to 7.4 billion. But the second figure on the right on the real story, deal count fell from 975 to 608. Down roughly 38%, while total dollar held flat, and 45% of first half 2026 capital set in rounds of $100 million or more. Fewer deals, larger checks. Capital is not scarce, it is selective. Investors are concentrating money in venture that can already evidence a return. Source Digital Health 2026. From growth first to return on investment first, that reflects to genuine regime change. In the pilot era, 2018 to 2023, adoption was measured in user and pilot. Future richness was a selling point. Capital was abundant, so discipline was optional. Value was asserted, usually in a vendor deck. We are now in the accountability era. Adoption is measured is cash flow and release capacity. Evidence of clinical and cost impact is required. Capital is rationed and hurdle rates are enforced. The figure below show how far adoption has come. 75% of US health system use or plan an AI platform in 2026, and among those who can quantify it, most report about a 2-time return. The practical consequence, a proposal that cannot state its own payback period no longer gets funded. What the investment actually costs. So let us build the case properly. starting with cost because business case fail more often from omitted cost than from overstated benefit. 3 layers: capital expenditure, license and platform build, hardware and network, integration with the medical record, data migration. Operating expenditure, annual subscription and support, cybersecurity and compliance, cloud consumption, and vendor management. And the layer that is almost always under budgeted, change costs, clinician training and backfill. The productivity chip during life, which is real and must be planned for. Workflow, redesign and governance, and continuous benefit tracking, because if you don't measure, you cannot claim. This is reference from Deloitte. For value stream, now the benefit side for distinct stream, and it matters enormously which one you rely on: revenue capture, incremental visit volume from release clinician time, better coding accuracy, fewer denials, new billable virtual service, cost avoidance, less overtime and agency staffing, lower admission penalties, fewer duplicate tests. Capacity release, clinician hour return to care, real value, but monetize off if those hours actually redeployed into unmet demand. Risk reduction, lower turnover and recruitment costs, fewer safety events, stronger audit resilience. Here is a critical point: only the first 2 land directly in the account. Stream 3 and 4 must be expertly converted into revenue or avoided costs. If you skip that conversion, they are benefit your finance director will never see and therefore cannot fund.
Pardon, Miss TV, a gentle reminder. We have
Okay,
about 5
finish.
minutes remaining.
Okay.
Oh.
The appraisal toolkit for tools is answering different questions: net present value, internal rate of return, payback in investment, benefit cost ratio. In practice, NPV decides IRR communicators, payback ratios and treasury, and benefit cost ratio ration the budget. Turning time into money, the conversion has 4 steps, and it's a management decision rather than a technical fact. Measure 60 to 90 minutes of documentation time saved per clinician per day. Price it at a fully loaded clinician cost of roughly $250 an hour. Value it $50,000 to $75,000 of recovered clinician time per clinician per year, and then the step that gets skipped, realize it that value exists only if the hours are pre-booked as visit or used to cut paid overtime. Okay, a 5-year model. Let me make this concert ambient documentation for 100 physician system in $1,000 discounted at a 10% cost of capital. Year 0, we invest $100,000. The Deloitte feature Year 1, 500,000 of net benefit, reflecting a partial year ramp because adoption is never instant. Years 2 to 5, 900,000 year steady state. The lower row is the cumulative discounted position. We are 800 down at the start, still 345 down after year 1 and cross into positive territory during year 2 at 398 by year 5, just 2.2 million. That give our headline numbers: net present value $2.25 million, internal rate of return 84%, payback 16 months, benefit cost ratio 3.8 times. On every criterion in this creates value, but be honest about what it rests on. One assumption that year 2 onward delivers $900,000 of realized auditable benefit. That is what we the next. The break-even curve, the same model as a curve, and the shape carries two messages. The first is the crossing point, month 16, that is consistent with Deloitte model for 14 months payback for a comparable deployment, which gives me confidence the model is not fantasy. And the second is the slope after that crossing. It is steep. Most of the value sits in years 3, 4, and 5. That has unpredictable and predicted governance implication if leadership change or budget tighten and program is abandoned in year 2. Just after the pain, just before the payoff, you destroy the very return that's justify it. What protects the return is not the technology, it is governance. Stress testing the case. So let us test the assumption. What if we don't realize the full benefit? At 60% realization, NPV is still positive, 1.03 million. At 80%, 1.64 million. Best case, 2.25 million. For variable, move the answer. The dominant one is the benefit realization rate. The variable management actually controls. Second, the cost of capital, moving the discount rate of 10 to 15% cut NPV and 1.87 million. Third, the adoption ramp, every quarter of July push, the whole benefit stream 1 quarter later. Fourth, license escalation and scope creep. The honest conclusion, the case survives a 40% shortfall. That tolerance is the argument for proceeding, and it is far more persuasive than a point estimate, which only invites you board to ask what happens if you are wrong. Okay. I will finish it. Okay. The conclusion: 5 proposition to close. One, finance is the binding constraint. Entrepreneurship and digital transformers strength services only when they clear a risk-adjusted hurdle rate. 2, capital has become selective rather than scarce. Fewer, larger round reward venture that can evidence return. 3, return is documented but denominated in time. Converting release hour into cash flow is the management act, not an automatic consequence. 4, publish a range, not a point, but a case that survives 40% shortfall is defensible. A single point NPV is not. 5, sustainability lower the cost of capital, measure clinical, social, and environmental performance is now priced into financing instrument, which bring me to the sentence of the screen and the argument of this whole talk. Strengthening healthcare services is in the end an act of capital allocation. Ladies and gentlemen, thank you very much for your kind attention through this session. Without further ado, I would now like to hand the session back to our moderator. The floor is yours. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Ms. Sylvia Reparati, for that insightful presentation. Now we move on to our final speaker for this session is Rahmat Ardhani, Master of Computer, a lecturer in the field of information. Master of Computer, lecturer in the field of information technology at Universitas Aisyah Surakarta, where he serves within the Faculty of Science and Technology. He's completed his bachelor degree at Amikom Yogyakarta and his master degree at Universitas Amikom Yogyakarta. His expertise span web programming, multimedia and design, and a wide range of digital tools from PHP, MySQL, Linux, and the others. He will presenting on the topic of empowering society through smart technology, innovation, digital transformation, and human-centered solution. Please welcome Rahmat Ardhani, Master of Computer. Rahmat Ardhani.
Assalamualaikum, Mr. Farid. Can you hear me?
Yes, loud and clear. Thank you for being
Okay.
here as a final speaker today.
Okay.
So whenever you're ready, the floor is yours.
Okay, I'm ready. Assalamualaikum warahmatullahi wabarakatuh. Honorable Rector, Vice Rector, Deans, and other participants. I Rahmat Ardhani. I from faculty member at Science and Technology. It's great honor to be here. In this session, I will share my presentation on the topic from smart society to from smart technology to smart society, digital transformation in era digital transformation in intelligent system. Can be, sir?
Wait for a while. We're under processing.
Oh, yes.
Okay.
Okay, this is my material.
Okay.
From smart technology to smart society. Yes. Okay, I want to open with single stance that capture the spirit of everything my will discuss today. The technology is not available because it advanced, but because it create creates meaningful impact for people and society. Okay, in this section, here is the path I will take together with you. The first, I will define the digital era and the force driving. The second, I will clarify what digital era transformation really means beyond the technology itself. The three, I will look for you at enabling technology, artificial intelligence, Internet of Things, big data, and cloud computing. Four, we will see smart society in action. Five, and especially important for research audience, we will confront the challenge and ethical question. Okay, next. The first, we are talking about digital era. We are left in what many scholars call the digital era. It is not simple about having more gadgets. It is a fundamental restructuring how people, device, and system relate to one another. The four forces define it. The first is hyper connectivity. People, device, are system. People, device, are system are continuously like through digital network. The second is a data-driven society in which data becomes strategic resource for decision making and innovation. The three is intelligent automation, where AI and smart system take over written tasks and rise efficient. Yes. The fourth is rapid innovation. New technology emerge at a pace that constantly creates both opportunity challenge. To put scale on this, by 2025, industry analysis estimate more than 21 billion connected devices weekly, and the global volume of data is projected to reach 175 zettabyte. These are not just imprecise number, they describe an entirely new environment in which society. The next, why digital era matter? So we does this digital era matter because it stands what is possible in digital era. Society can access information more easily and more equitable than at any point in history. It can improve productivity and efficiency across every field. It can create entirely new business and economy opportunities. It can enhance the quality of education and healthcare services, reaching people who were vastly underserved. And maybe most importantly, focus as research. It allows us to develop innovative solution to long-standing social challenge.
Then Mr. Rahmat Ardhani,
Yes,
your time, 5 minutes left for presentation.
definitely. Okay. Okay. Next, this I will presentation the important materials. Digital transformation is more than technology. This brings us to crucial clarification. Digital transformation is more than technology is one of the most common misunderstanding, and I want us to be precise about it. True transformation rests on four pillars. The first is people. developing digital skill and cultivating a culture of innovation technology without capable people achieve very little. The second is process, redesigning our workflow to become more efficient and agile, rather than simple digitizing all broken process. The third, the technology itself, leveraging AI, IoT, cloud computing, and big data enablers. And the fourth, often overlooked, is culture, encouraging collaboration, continuous learning, and adaptability. Okay, technology enabling smart society. Let me us examine the enabling technology more closely. The four that most powerfully drive a smart society. The first as artificial intelligence, AI enable machine to learn, to analyze, and to make intelligent. Personalization, it underpins automation and tailored service. Second, the Internet of Things or IoT, which connect device and system to collect and exchange data in real time, creating smart environment and more efficient use of resource. Third, big data analytic, which transfer vast quantities of raw data into valuable insight, supporting better and faster decision. And for cloud computing, which provide flexible, scalable, and scalable digital service on demand. Okay. Okay. Next was how smart technology empowering society. Where do actually see smart technology empowering society? Let us walk through several sectors in healthcare. We see AI diagnosis, telemedicine, and remote patient monitoring, extending care beyond the walls of hospital. In education, we see online learning, AI power tutoring, and personalized education that adapt to each learner. And in ar- agriculture, agriculture, so vital for country like our, we see precision farming, smart irrigation, and crop monitoring, helping farmer produce more while using fewer resources. So, smart technology in healthcare, because healthcare illustrate the promise so vividly. Let us look the deeper at for application AI analyze medical data and image to enable early accurate disease detection. The impact is faster diagnosis and more accurate treatment decision. Telemedicine over remote consultation that remove geographical barriers. The impact wider access and fewer unnecessary hospital visit. Wearable device continuously monitor vital insight in real time. The impact is early risk detection and shift toward prevention. And smart hospital bring together digital record and automatic clinical workflow. So maybe because the time I'm closing in this discussion. Let me where I began. Technology is not available because it advances, but because it creates meaningful impact for people and society. Our tax and research educator and citizen it to ensure that the smart society we are building in inclusive, ethical, human-centered. Thank you very much for your attention. I will be happy to take your question and to hear your perspective. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Mr. Rahmat Ardani, and thank you to all three of our speakers in this session for their valuable contribution. We'll now open the floor for a combined discussion with our last three speakers. Before we begin, let me uh, uh, I would ask you that you please first use the chat box or raise hand feature before speaking. State your name and affiliation. Keep your question brief and specific, and direct it to a particular speaker if it's applicable. And for all of the participants, don't forget to present in the Google form that we share. Okay, we have several questions from chat box. Let me begin from the first one. Alice. Okay, there is from Dita Mirawati. Hello, my name is Dita from the Physiotherapy Study Program at Aisyah. We're waiting for the other. Yeah. As we uh, continue this Q&A session. Okay, let's continue this Q&A session. We begin from the question from Dita. She asking for Asita, Miss Asita. Hello, my name is Dita from the Physiotherapy Study Program at Aisyah Surakarta, Universitas Aisyah Surakarta. Thank you for your excellent presentation. My question for Miss Asita, I would like to ask, With the rapid development of AI, wearable technology, and telerehabilitation, how can technology effectively support geriatric physiotherapy without replacing the critical role of physiotherapists in the clinical decision making and personalized patient care? Thank you.
Okay, thank you. Okay, I will to answer the question to Mrs. Dita. Yeah. Technology can improve access through telerehabilitation, increase measurement, precision through wearable sensor and motion capture system. It has engagement through virtual reality and gamification, support clinical decision through artificial intelligence, and improve continuity through remote monitoring and digital communication. That however, technology should support, not replace, the physiotherapist clinical reasoning, the professional supervision, and therapeutic relationship is just to be doing the by physiotherapy. Yes, maybe that's my answer to Mrs. Tita. Thank you. So this great question. Okay.
Okay, thank you, Ms. Asita, for your wonderful answer. And I think Ms. Tita will love your answer because she overreact during your answer the question. Let's move on to another audience. I think Destra want to ask for someone. Destra, can you hear me and begin to ask? Can you unmute your microphone? I think there's trouble. Where is he? Or okay, let's change the Viola. Can you unmute your microphone to Viola, can you hear me? Okay.
Yes.
Okay, you can start to ask.
Okay. This one. What should universities and students prepare for the future of smart technology and digital society?
So, okay, you asked for who?
Mr. Rahmat Ardani.
Mr. Ahmad Ardani. Okay. Okay, to Mr. Ahmad Ardani, you need to repeat the question or you can just answer.
Tes. Yes, the repeat question, Mrs. Viola.
What should universities and students prepare for the future of smart technology and digital society?
Okay, the student, yes, for prepare in digital era society. The first, we provide the skill, yes, for digital era. That is skill programming, skill that skill to use AI, yes, for research and for the studies, yes. This is very much to feature for the digital era, yes. you can study for programming for the make new product. Yes, the future is maybe creates the new business. Yes. Example, the marketplace, you can make that, and maybe you can make uh, digital lending, yes, for the business. That's my answer, Mr. Farid.
Okay, thank you, Mr. Ahmad Ardani. Viola, is it enough? Okay, I think that's enough. Okay, I'll back to the who to the raise chat box. Okay, there is another question. Okay, Destra, can you start to open your mic? Okay. Nope, you're still okay.
Okay, thank you. Assalamualaikum, Miss Asita. Please allow me to introduce myself. My name is Rahtani Putra Prasetyo, and my student ID is 202512014. I am a diploma-3 nursing student at Universitas Aisyah Surakarta, Indonesia. With your permission, I would like to ask a question. My question is, how can technology improve access to geriatric physiotherapies? Thank you.
Thank you, Destra. Miss Asita, can you start to
Okay. Okay, Mr. Farid, I will to answer the question. So, how can technology improve access to geriatric physiotherapy? Technology can improve access to telerehabilitation and hybrid care models, allowing older adults to receive supervision rehabilitation at home or in a community settings. However, remote care should be combined with a person's assessment when necessary to ensure safety and appropriate clinic management. Okay, that's my answer to Mr. Destra. Thank you for your question.
Okay. Thank you, Miss Asita, for your answer. And I hope Mr. Destra will be happy of your answer. Okay, we'll move on to another question. We're going to the Muhammad Triwibowo. Hello, my name is Muhammad Triwibowo from Universitas Aisyah Surakarta. I want to ask a question for Miss Civi Erikawati. So, what is the biggest challenge in achieving a positive return on investment or ROI from digital health project? Thank you.
Thank you for the question, Mr. Trivibowo. I will answer. The biggest challenge is benefit realization, not the technology itself. Many hospitals successfully save clinician time through digital solution, but they fail to convert to save hour into measurable financial value. To achieve a positive return on investment, organization needs strong governance, clear benefit ownership, workflow redesign, and continuous performance monitoring. Without this element, time saving may improve staff satisfaction, but will not generate measurable financial returns.
Okay, thank you, Stevie. Let's move on to another question from Evelyn Nidia Dava. It's for Stevie Erikawati again. Hello, my name is Evelyn Nidia Dava from Universitas Aisyah Surakarta. First, I need to say thank you for the insightful presentation. I have a question. regarding digital transformation and financial consideration, Ms. Jiverikawati, you emphasize that digital transformation should pass a financial test. Does that mean hospitals should reject innovation with high clinical benefit but low financial return?
Thank you for the question, Miss Evelyn. Not necessarily. My point is that every innovation should be evaluated from both a clinical and a financial perspective. Some technologies may generate significant social or health benefit that are not immediately reflected in financial return. In those cases, a hospital can consider alternative financing mechanism such as government grants, blended finance, or outcome-based funding. The key is to ensure that investment remain financially sustainable while continuing to improve patient outcomes.
Okay, thank you, Ms. Jiverikawati. Let's move on to another question. I think it's become the last question because we're going to out of our time. So the last question is from Andika Wahyu Utami from Universitas Aisyah Surakarta. The question is for Mr. Rahmat Ardani. She asked you, how can we ensure that digital transformation benefits all members of society, not only those who already have access technology? Thank you very much for your insightful response.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for question Andika Wahyu from Aisyah University of Surakarta. I believe that includes digital transformation required more than simple providing advanced technology. There are at least three important aspects that must be considered. The first, digital infrastructure must be available and affordable. Many people still face limitation in the internet connectivity, digital device, and access to online service. Without equal access, digital transformation may increase inequality rather than reduce it. The second, digital literacy is essential. People need to skill to use technology safely, critically, and productivity. This include not only technical skill, but is the ability to evaluate information, protect the personal data, and adapt to technology challenge. The third, we need human-centered approach. Technology should be designed based on the needs different group in society, include student, elderly people, communities, and person with disabilities. Inclusion success digital transformation is not measured by how much technology we adopt, but by how many people are empowered by that technology. That's my answer, Mr. Farid, for Mr. Andika.
Okay, thank you, Mr. Rahmat Ardani. Okay, sorry, apologize guys, because we're reached at the end of our time for questions. Thank you to everyone who participated in these discussions. Now we will now process the presentation of certificate of appreciation to our remaining distinguished speaker. Please accept this certificate, virtual certificate of appreciation for our speaker. Okay, on behalf of the organizing committee, I would like to once again thank you for our distinguished speaker, Prof. Aliza Abu Hasim, Dr. Awanis Romi, Professor Alia Wiri, Ms. Asita Rohmah Munawasito, Master of Physiotherapy, CV Erikawati, Master of Management, and Mr. Rahmat Ardani, Master of Computer, for sharing their research and insight with us. I would also like to thank you, all of you, of our participants, for your active engagement and thoughtful questions. This concludes our core session of the international webinar From Knowledge to Impact, Advancing Health Technology and Economy. Nasruminallah wa Fatum Qarib. I will now hand it back to our MC for the closing statement. Thank you very much. Enjoy the rest of the webinar. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay. Okay, ladies and gentlemen, before we conclude today's international webinar, I would first like to extend our sincere appreciation to our respected moderator, Mr. Farid Muhammad Raufifuddin, for his excellent moderation and for getting today's scientific session with professionalism and dedication. We also express our deepest gratitude to all of our distinguished speakers for sharing their valuable knowledge, expertise, and inspiring insight throughout today's webinar. So, ladies and gentlemen, we have now come to the end of today's international webinar. On behalf of the organizing committee, I would like to express our heartfelt appreciation to the Honorable Rector of Universitas Aisyah Surakarta and the university leadership, our distinguished speakers, our respected moderator, and all participants for your presence, support, and active participation throughout today's event. We sincerely hope that today's webinar has been beneficial and has inspired new ideas, meaningful collaboration, and continuous learning for all of us. Thank you once again for your participation and valuable contribution to today's international webinar. Wassalamualaikum warahmatullahi wabarakatuh. Have a pleasant day, stay healthy, and we look forward to welcoming you again at the future event hosted by Universitas Aisyah Surakarta.
The city of Surakarta, better known as the city of Solo, is famous for its slogan, the spirit of Java, which means the soul of Java, a city that adapts its image as the center of Javanese culture, people who maintain local wisdom with global thinking. Aisyah Surakarta University is present as one of the universities in the city of Surakarta, which adds to the charm of the world of education in Nusantara. The University of Aisyah Surakarta has gone through a long historical process of civilization in transforming forms. Founded in 1966, starting from the Aisyah University Midway School, then in 1981 became the Aisyah Surakarta School of Nurse. In 1997, became Midway Academy Aisyah Surakarta. In 2002, established the Aisyah Surakarta Nursing Academy. In 2005, the College of Nursing was established Health Science, Aisyah Surakarta, and in 2020 has been transferred into Aisyah Surakarta University. Currently, Aisyah Surakarta University comes with 3 choice of faculties and 11 study programs. Faculty of Business and Economy with study program, Bachelor of Entrepreneurship, excellent in business innovation skill and creativity based on digital, Bachelor of Retail Management, Excellence in Technology-Based Retail Management, Faculty of Science and Technology, with undergraduate program in Information System and Technology. Excellent in System Service and Information Technology with the integration of Artificial Intelligence. Faculty of Health Science with study program Bachelor of Hospital Administration. Excellence in Digital-Based Hospital Administration. Bachelor of Midwifery. Excellence in Tibun Nabawi. Diploma for Physiotherapy. Excellence in Geriatric Physiotherapy. Diploma 3 Nursing. Excellence in Wound Care. Bachelor of Nursing. Excellent in Disaster Management. In addition, the University of Aisyah Surakarta has nurse provision, midwife provision, and midwifery transitional programs. Educational activities at the University of Aisyah Surakarta are supported by sophisticated and modern facilities, equipped with a studio, smart classroom, discussion corner, digital library, mini hospital, Aisyah Pratama Clinic, and various laboratories that make learning activities possible anytime and anywhere. Aisyah Surakarta University also prioritizes Islamic values in the learning process to produce graduates who excel intellectually, socially, and spiritually. The Al-Islam and Kemuhammadian program Aisyah University of Surakarta is meant to deepen religious knowledge for students. University Aisyah Surakarta provide one-day service, a service that makes it easy for you to become a student of Aisyah Surakarta University. Aisyah Surakarta University provide opportunities to excel and win scholarship. Scholarships are obtained from Aisyah Surakarta University, Nazismu, government partner of Aisyah Surakarta.
Just one more step, you can get all these conveniences by registering yourself through this link. Be better, be Unisa.
The city of Surakarta, better known as the city of Solo, is famous for its slogan, the spirit of Java, which means the soul of Java, a city that adapts its image as the center of Javanese culture, people who maintain local wisdom with global thinking. Aisyah Surakarta University is present as one of the universities in the city of Surakarta, which adds to the charm of the world of education in Nusantara. The University of Aisyah Surakarta has gone through a long historical process of civilization in transforming forms. Founded in 1966, starting from the Aisyah University Midwifery School, then in 1981, became the Aisyah Surakarta School of Health Nurse. In 1997, became Midwifery Academy Aisyah Surakarta. In 2002, established the Aisyah Surakarta Nursing Academy. In 2005, the College of Nursing was established Health Science, Aisyah Surakarta, and in 2020 has been transferred into Aisyah Surakarta University. Currently, Aisyah Surakarta University comes with 3 choice of faculties and 11 study program. Faculty of Business and Economics with study program, Bachelor of Entrepreneurship, excellent in business innovation skill and creativity based on digital, Bachelor of Retail Management, excellence in technology-based retail management, Faculty of Science and Technology with undergraduate program in Information System and Technology, excellent in System Service and Information Technology with the integration of artificial intelligence, Faculty of Health Science with study program, Bachelor of Hospital Administration, excellence in digital-based hospital administration, Bachelor of Midwifery, excellence in Tibun Nabawi, Diploma for Physiotherapy, excellence in Geriatric Physiotherapy, Diploma